The following podcast is part of a certified educational activity titled Risk Assessment and Treatment Initiation, successfully jumpstarting the Adjuvant CDK4/6 inhibitor treatment journey in HR-positive, HER2-negative early breast cancer. Access the entire activity and complete the post-test at peerview.com/ARM860. Downloadable slides and practice aids are also available.
Hello, I'm Erica Mayer. I'm a medical oncologist specializing in breast cancer at Dana-Farber Cancer Institute in Boston. And I'm very excited to do a really great activity with you assessing risk and treatment initiation, successfully jumpstarting the Adjuvant CDK4/6 inhibitor treatment journey in hormone receptor positive, HER2 negative early breast cancer. So our goals for today are to improve your skills in risk assessment and development of individualized treatment plans for patients with high risk, hormone receptor positive, HER2 negative early breast cancer, and to equip you with strategies for providing guidance and support for patients with high risk, ER positive, HER2 negative early breast cancer who are candidates for treatment with adjuvant CDK4/6 inhibitor and endocrine therapy. Okay, so let's get started with a case. Here's your patient. Her name is Tina. She is a 58-year-old postmenopausal woman. She underwent a routine screening mammogram and was found to have a mass in the left breast. Diagnostic mammogram and ultrasound showed a 3-centimeter mass with enlarged and suspicious axillary lymph nodes. So she had a core biopsy of the breast, which showed invasive ductal carcinoma grade 3, ER positive 95%, PR positive 25%, and HER2 negative. She also had an axillary lymph node biopsy, which confirmed the presence of breast cancer cells in the node. So she's clinically node positive. She had systemic staging scans, which showed no evidence of distant metastatic disease. She had germline genetic testing, which was negative. So she moved forward to upfront surgery. She had a left mastectomy and axillary lymph node dissection. And findings from surgery showed a 2.5 centimeter tumor in the breast, grade 3 invasive ductal carcinoma, and 1 of 3 axillary lymph nodes were involved. An oncotype was sent on the tumor tissue after surgery, and this returned with a score of 28. So following surgery, she saw her breast surgeon in follow-up. 2 weeks after surgery, she was healing well. And she had a pre-surgical appointment with medical oncology. Now she's coming in for her post-operative appointment. Now it's 3 weeks after surgery. She is coming in to discuss results and discuss next steps in management. So how do we assess risk? Well, we want to think about many features. We want to think about clinical pathologic features, genomic features, and additional relevant factors that really give a more comprehensive assessment for each patient's personalized risk of recurrence, and that gives a little more precision around an estimate of risk that can help guide treatment decisions. And I like to think about it in 2 main categories. First, we have our standard clinical pathologic features. These are things we've always used. Stage, like anatomy, how much disease is there and where is it? Size and nodal status. We want to think about tumor biology, and this includes the tumor grade. And here's also where genomic testing such as oncotype fits in, teaching us more about the personality of the cancer. One might put Ki-67 in this category as well. It is a prognostic biomarker, but it is not used routinely in all pathology offices due to some of the variability in testing. And so if it's used in your office, that does belong in this category, but it may not be offered by your pathologist. And then we also want to think about other relevant factors when we're assessing risk and using that in treatment decision-making. For example, a patient's age, their menopausal status, very importantly, their comorbidities and concomitant medications. And I would also put in here some of the patient preference issues and how patients interpret their risk and how that risk influences how they approach shared decision-making between a patient and their provider. Now, when we think about risk, this has been in some ways translated for us in the very large adjuvant CDK4/6 inhibitor trials. These 2 trials are Monarch E trial, which looked at the CDK4/6 inhibitor abemaciclib, and the Natalie trial, which looked at the CDK4/6 inhibitor ribociclib. In both trials, these agents were added to standard adjuvant endocrine therapy. These are both registrational trials that led to respective approvals of their drugs. And let's just consider how risk was defined in these trials. So first, Monarch-E was a trial designed for high-risk node-positive breast cancer. The majority of patients were enrolled in what is considered cohort 1, which included patients who had 4 or more involved axillary lymph nodes, or 1 to 3 axillary nodes, and an additional high-risk feature, which could be a larger tumor size, 5 centimeters or more, a higher grade, so grade 3 cancer. And cohort 2, which was added a little bit later towards the end of the trial, included another high-risk feature, which was an elevated Ki-67 of 20% or more. And so that comprised the eligibility, but again, all the patients were node positive. Natalie had slightly different eligibility criteria, and perhaps one might think about this as broader eligibility, as this included node positive patients, but also high-risk node negative patients. So all patients with stage 3 disease were included, all patients with stage 2B disease, all patients with stage 2A node positive disease, so essentially all node positive patients. And then the group where we were looking for the higher risk node negative is the stage 2A patients, the T2N0 patients. And these patients needed to have either grade 3 disease, or if they were grade 2, they needed an additional high risk feature, which could have included an elevated Ki-67 or a higher risk genomic score, for example, an oncotype score of 26 or more. Notably, if patients had grade 2 and did not have one of those high risk criteria, or if they were T2N0 grade 1, they were not eligible for the Natalie trial. So it was not open for every single T2N0 node negative patient. It was only the high risk patients. So keeping all of that in mind, let's go back to our case. And just as a reminder, she had upfront surgery. She has a T2 sized cancer, 2.5 centimeters. It is high grade. It does have a high oncotype score of 28. And she does have lymph node involvement with 1 involved axillary node. So she's healing well from surgery, and she's coming in to discuss results and discuss next steps in management. So in thinking about our case, some questions to keep in mind. Let's work through these questions. First, how should we categorize her risk status? She's node positive. Is she a lower risk node positive or a higher risk node positive? If we're thinking about the criteria used in the trials, particularly in Monarch-E, she's node positive with 1 positive node. She's grade 3. She's high oncotype. We don't have Ki-67, but that's okay. We have the other high-risk features. So she does fit into the higher risk node positive category, thus making her a potential candidate for an adjuvant CDK4/6 inhibitor. What factors indicate her risk? Well, we've just gone through some of those anatomic features, such as her node status, and we've also talked about the biologic features, the grade and the elevated oncotype score. So then how do you share this with the patient? What does that higher risk mean, and how does that translate into the need to intensify treatment? And here's kind of an art of oncology piece. When you're meeting your patient and you're reviewing pathology and results with your patient, here's where it is probably important to call out some of those features and share with them how those resonate with you as a provider. How do those make us feel about that patient's risk? And how can we translate that knowledge and perhaps that concern that they could be in a higher risk category into action and into ways to meet that risk and address it with the introduction of additional medications? So let's move on and talk about how we are offering adjuvant CDK4/6 inhibitors. This is data from a Flatiron Health database analysis looking at U.S. institutions, looking at patients who had high-risk node-positive early breast cancer, and then looking at who was taking adjuvant abemaciclib. And the results suggested that only about 40% of the patients who were potentially eligible were receiving drug, with about 60% not receiving drug. Now, we don't know exactly why those patients weren't receiving medication, but it is notable that the majority were not getting it, even though they fit into the eligibility category. Let's review data from the phase 3 Monarch-E study. Just as a reminder, Monarch-E is a study in hormone receptor positive, HER2 negative, high risk, node positive early breast cancer. This year at ESMO, we saw a landmark 7-year analysis follow-up from Monarch-E. So the trial has been monitored very closely over many years. And this was a follow-up that looked not only at the primary endpoint of invasive disease-free survival, but also looked at the endpoint of overall survival. And now, at this 7-year landmark moment, there is an overall survival benefit seen for the patients who received the 2 years of adjuvant abemaciclib. The benefit was an overall, an absolute benefit of 1.8%, but the relative reduction in risk of death was 15.8%. On the one hand, one might consider that to be a fairly narrow benefit, but remember, these are adjuvant patients in the curative setting, and this means that we are making a difference in the lives of these patients with the use of adjuvant abemaciclib, hopefully curing them of breast cancer with the use of this agent, and now with a statistically significant improvement in overall survival. In reviewing the benefits seen across the pre-specified subgroups, there was a consistent benefit from the use of abemaciclib in this setting compared to not using abemaciclib. I would point out a few groups in which I think this is particularly important. First of all, there was benefit seen in both premenopausal and postmenopausal patients, and interestingly, even a stronger benefit in premenopausal in our youngest patients. There was also a benefit seen in older patients 65 or older. Additionally, there was a consistent benefit seen in grade 1, grade 2, grade 3. And so irrespective of tumor grade and perhaps some element of tumor biology, the abemaciclib was helpful in preventing death from breast cancer. Additionally, there was follow-up on the primary endpoint of invasive disease-free survival. And now at the 7-year landmark analysis, we see a preserved benefit with an absolute difference of 6.5%, a hazard ratio of 0.734. Very consistently in the years in which monarchy has been followed, the benefit from the use of adjuvant abemaciclib emerged soon after patients finished the 2-year course. It widened, and now it has been maintained. So it's really great to see that after that initial 2-year exposure, the benefits seen from that treatment are preserved and are maintained over the years ahead. Additionally, there is a sustained benefit in distant recurrence-free survival. So this is telling us that the IDFS benefit is really built on the prevention of distant recurrence events. We can see there's an absolute benefit of 5.1%, a hazard ratio is about 0.75. So it's telling us that the use of abemaciclib is not only preventing disease recurrence, but it's preventing distant recurrence, which is what leads to the overall survival benefit. Now let's turn to the phase 3 NATALY study. This year at ESMO, we saw an updated analysis from NATALY. Now this is a 5-year analysis. Primary endpoint of NATALY is invasive disease-free survival. And with the long-term follow-up, we can see that the initial benefits that were presented at first reports from the trial have been preserved and actually not only maintained, but have grown. And at the current time, the delta between the two arms is 4.5%. Corresponding to a hazard ratio of 0.716. This tells us that those early years, the 3 years on ribociclib, have led to consistent and maintained improvements in preventing disease recurrence. And we have that now confirmed years after patients finished their initial treatment. With this updated analysis, very importantly, there was an update for invasive disease-free survival by nodal status. So remember, NATALY includes not only node-positive patients, but also node-negative patients. The early reports from NATALY were a bit immature in the node-negative population. There were not that many events, and statistically, it didn't quite meet significance. Now, with longer follow-up and more events in this category, we can see there is definitively a difference between the arms. There's an absolute difference of 5.7%, and that corresponds to a significant hazard ratio of 0.606. And so this helps confirm for us the benefit of adjuvant ribociclib, not only in the node-positive population, but also in the node-negative population, which, of course, is a large population of patients in our practices. Overall survival for NATALY remains immature, but continues to trend favorably. There is an emerging benefit from ribociclib in the ribociclib arm with a delta of 1.6% and a hazard ratio of 0.8. However, the data does remain immature, so we continue to follow. It is, however, quite reassuring that it is trending favorably, and hopefully with longer follow-up, we will see a benefit in overall survival. Okay, so let's get back to our case. So remember, this is the patient with node-positive disease, T2 sized tumor, grade 3, oncotype is 28. So she's high risk node-positive disease. And she comes into your clinic today to talk about therapy options. Now, she already had met before surgery, so she's already heard a bit about what she might have in terms of systemic therapy after surgery. But she's had a lot going on. She can't really remember those details, and she wants to go over everything comprehensively with you. So, as we consider how to approach this patient and counsel the patient, let's first consider what some of the decision points are. So, first, what treatment options are we going to review with the patient now that she has completed surgery and it's clear she has high risk disease? And there are some options listed here. I'll just point out radiotherapy. As part of local regional management, we could likely defer to the radiation oncologist to discuss with her, but in the setting of node-positive disease after mastectomy, she's likely a candidate for post-mastectomy radiation. Remember, she had an oncotype of 28, and current guidance generally would recommend administration of adjuvant chemotherapy for that score. And so you are likely talking about chemotherapy with her. But I also think it's very important to really reinforce with a patient that for hormone receptor positive early breast cancer, the most important therapy that she can be taking is adjuvant endocrine therapy. For me personally, that's what I always lead with when I'm talking to patients to make sure that they understand the importance of the years and years of adjuvant therapy that we are recommending to them. And this is also a good time to introduce the adjuvant CDK4/6 inhibitor if you haven't done that already, because we know that she's a candidate for either agent. And this should be brought up at this time so it doesn't come as a surprise to her later. Now, one thing for us to think about is what types of communication strategies and tools could we use to help your patient understand risk and help her or him participate in shared decision making. And I do think some of the features that we discussed before, reviewing the clinical pathologic features that define risk, reviewing what we know about risk in high-risk node-positive patients, and also reviewing some of the data from the recent trials demonstrating the substantial benefits we get from each part of our systemic therapy repertoire can be very helpful. So patients really understand that if you're offering, shall we say, the kitchen sink to them, that we're doing it actually very intentionally because it's a data-driven decision, and we know that each step of the process is going to be helpful and meaningful for them. So next steps for this patient: she does her chemotherapy, she completes radiation, she initiates adjuvant endocrine therapy, and we schedule a follow-up appointment to discuss adjuvant CDK4/6 inhibitor therapy. So patient now comes to her next appointment to discuss her adjuvant CDK4/6 inhibitor. So let's think about what are some of the important aspects that we want to explain to the patient. I think it's important to discuss, maybe not on a super granular level, but review the data from the clinical trials and discuss why it's important that we offer these drugs. What are we getting from these drugs? And in particular, I think reviewing the data for IDFS, for overall survival, from the carryover effect, for how powerful these drugs appear to be in improving outcomes for patients. I think it's also important to make it really personal and say, why is this patient, why are you a good candidate for this therapy? Not just the trial of 5,000 people, but why is this important for you as a person, and make it personal. It is important to review some of the differences between the drugs and review in detail the side effect profile of abemaciclib, the side effect profile of ribociclib, and whether the patient has any comorbidities or other medical features that might predispose to sensitivity to any of the toxicities. It's also important to review the follow-up program and how patients are monitored, including the need for EKGs or laboratory testing. And, and this may not be the top topic on day one, but the fact that one drug is 2 years, one drug is 3 years, so patients know what to expect. Adherence is important. We need patients to stay on therapy. And I think we as providers kind of assume patients are going to take drugs because we know how important they are, but we know in the real world sometimes that doesn't happen. And so reviewing why it's important to be adherent, but also the need for good communication. And if patients are struggling with toxicity, if they're questioning, why am I doing this, that they will call and talk to us and come in for a visit, talk on the phone, but make sure they feel well supported and that this is a shared decision so that they can have some ownership, and hopefully that will motivate them to stay on therapy. And then, some tricks of the trade. How can patients really maximize their success? For example, if the drug is going to cause diarrhea or has risk of diarrhea, having Imodium ready and explaining when to take it, how to communicate about the side effect, when to hold drug, so that the patient feels really prepared. Always important to talk about healthy diet and exercise in the survivorship setting. And again, the importance of communication. But overarching, we need to know our patients as people and understand what their needs are, what their preferences are, and so we can meet their goals in a shared fashion. So, as next steps for this case, our patient agrees to start treatment with an adjuvant CDK4/6 inhibitor, which I think we all agree with because there are high risk features in her case, and we want to meet that risk with the introduction of a CDK4/6 inhibitor. I think in clinic, we continue sometimes to struggle a bit with selection of an adjuvant CDK4/6 inhibitor in terms of which one should I select. And there's certainly a lot of features and factors that go into that type of selection. The new data that we have seen from the long-term follow-up from Monarch-E and from Natalie is definitely important as we continue to make these decisions in clinic with our patients. Personally, I find the overall survival data from Monarch-E and the 7-year follow-up is very compelling. We always prioritize survival for our patients. We want to select agents which are going to improve their survival and help cure their breast cancer. And I think particularly for abemaciclib, given the maturity of the data for our high-risk node-positive patients, this is a very compelling agent in those situations. I think of abemaciclib particularly for multi-node positive patients or patients where I really have great concerns about their risk. Regarding Natalie, again, I find it very compelling to see the strength of the data in the node negative population. There's a lot of patients who we encounter who have T2N0 disease. It's a much more common presentation than some of our high-risk node positive presentations. And so being able to extend the benefit of an adjuvant CDK4/6 inhibitor to those patients with greater confirmation that it's going to provide benefit for them in reducing the risk of cancer recurrence is very compelling and certainly makes it worthwhile to discuss that as a treatment option for node-negative patients. Now, it may not be the right choice for every node-negative patient, and certainly there's other features which are important that play into how we make these decisions for patients. I think in particular, what has been compelling from the CDK4/6 inhibitor literature is that there really is a growing signal of the benefit of these drugs in our younger and our premenopausal patients. And so I think definitely for our younger patients, it really is important to talk about CDK4/6 inhibitor and offer and try to encourage patients to consider trying. In the context of that, I would also add that we increasingly have been learning from long-term follow-up from trials like SOFT and TEXT how to optimize adjuvant endocrine therapy in our younger node-positive patients or our younger high-risk patients, and including things like ovarian suppression and extended duration adjuvant endocrine therapy is really important, as well as offering an adjuvant CDK4/6 inhibitor. So I think for our younger premenopausal patients, we really need to consider how to be very comprehensive when we are offering our best therapies and our most effective therapies to this important patient population. Now, back to our case, let's think about just some variations and how we could address them with a patient. So perhaps our patient is saying she's tired. She's had a lot of therapy. She's had chemotherapy, all the local therapy. When or how is she going to be ready to take a CDK4/6 inhibitor? And that's very normal. I encounter this in my clinic frequently. But, the good thing is that for both Monarch-E and Natalie, patients did not necessarily initiate their a CDK4/6 inhibitor immediately, but there was actually a window of several months after completion of surgery or completion of chemotherapy. And so I do think it's important to allow patients a little grace and some time to recover from whatever they've been receiving before to get them to a point where they're ready to start. We certainly want them to take their best step forward with their treatments and ensure as best we can that they're not going to have an immediate adverse event that would make it hard for them to take their therapy. If a patient refuses therapy for personal reasons, well, that's their decision. And we want to just support our patients as best we can and educate them about their data, about the data for these drugs. And then they're going to make their decisions. And then there are some patient-specific features which are very important to keep in mind if we're deciding between the available CDK4/6 inhibitors. For example, if a patient is taking a medication which is known to be QT prolonging, and it's a medicine that they have to be on, then ribociclib may not be the best choice for them, since we do need to do EKG monitoring and make sure there's not long QT. That might be a situation where abemaciclib is a better choice. If a patient has already baseline GI issues and already is struggling with managing diarrhea, they may not want to take a drug that could also cause diarrhea. And so in that situation, selection of ribociclib may be a preferred choice. So, it's really fortunate for us that we have two available approved agents, and we can select and tailor what we recommend to patients based on what's going to be the best fit for them, which fits them best in terms of the available data and their cancer presentation. And of course, wanting to support them with whatever they decide and help maintain adherence to oral therapies, adherence to endocrine therapy, so they have their best benefit from treatment. Thank you for participating in this AI-driven educational activity. I hope you found it interesting and useful for your practice. Please be on the lookout for part 2 of the educational curriculum.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/ARM860.